If you are over 65 and every time your blood pressure is checked, you feel a little anxious before the number appears on the screen, this video is for you. Maybe you have been told your blood pressure is a little high. Maybe your doctor said your goal should be under 130 over 80. Maybe someone looked at your reading, frowned, and immediately mentioned another medication. And because you care about your health, you probably listened. You tried to eat less salt. You walked more. You worried more. You checked your numbers at home and felt guilty every time the top number was not as low as you expected. But here is the part many older adults are never told clearly enough. After 65, blood pressure is not just about getting the number lower. In fact, for some seniors, pushing blood pressure too low can create a completely different set of problems. Dizziness, weakness, falls, fatigue, kidney stress, brain fog, and in certain cases, reduced blood flow to the heart itself. I'm Dr. Amanda Collins, and on this channel, I help adults over 60 understand the health information that often gets rushed through in a short medical appointment. Before we go deeper, please take a moment to like this video, subscribe to the channel, and share it with someone over 65 who checks their blood pressure, but may not fully understand what those numbers really mean. This conversation could help them ask better questions at their next appointment. Now, let's begin with something very important. For years, the general message around blood pressure has been simple. Lower is better. The lower you can get it, the safer you are. That message sounds logical, but it is not always complete, especially when we are talking about older adults. Your blood pressure reading has two numbers. The top number is called systolic pressure. This measures the force inside your arteries when your heart squeezes and pushes blood forward. The bottom number is called diastolic pressure. This measures the pressure inside your arteries while your heart is resting between beats. For a long time, doctors paid a lot of attention to the bottom number, but as research developed, especially in adults over 50, the top number became more important because it often rises as arteries become stiffer with age. This is why many older adults develop something called isolated systolic hypertension. That means the top number may be high, while the bottom number may remain normal or even low. This happens because aging arteries are different from younger arteries. When you are younger, your large arteries are flexible. They expand with each heartbeat and help smooth the flow of blood. But as you age, those arteries naturally lose some of that flexibility. They become stiffer, less elastic, and less able to absorb the pressure created by each heartbeat. So the top number rises. But here is where the problem begins. A 45-year-old with a blood pressure of 150 over 95 and a 78-year-old with a blood pressure of 150 over 62 are not the same clinical situation. The numbers may both look high, but the body behind those numbers is different. The arteries, the kidneys, the brain, the fall risk, the medication tolerance, and the overall physiology are not the same. And yet, many older adults are treated as if the goal is simply to push the top number down as much as possible. That can be helpful for some people, but for others, it can be risky. There was a major blood pressure study that changed the way many doctors think about treatment targets. It compared a standard blood pressure target with a much more aggressive target. The aggressive group had fewer major cardiovascular events, such as heart attacks and heart failure. Because of that, the study received a lot of attention and helped influence stricter blood pressure goals. But the headline was not the whole story. The group treated more aggressively also had more serious side effects. There were more cases of kidney injury, more electrolyte problems, more fainting, more episodes of blood pressure dropping too much. And for older, frailer adults, those side effects are not small details. They can completely change quality of life. A fall after 70 is not just a fall. It can mean a hip fracture, surgery, hospitalization, loss of independence, and months of recovery. For some seniors, one fall becomes the event that changes everything. That is why the real question after 65 is not, how low can we get this number? The better question is, what is the safest and most effective blood pressure range for this specific person? That means your target should consider your age, your kidney function, your heart history, your balance, your medications, your risk of falling, your energy level, and whether you feel dizzy when standing. This is not about ignoring high blood pressure. High blood pressure can absolutely damage the heart, brain, kidneys, and arteries over time. It increases the risk of stroke, heart attack, heart failure, and kidney disease. So yes, it matters. But after 65, treatment should become more precise, not more automatic. A number that is perfect for one person may be too aggressive for another. A target that makes sense for a strong, active 66-year-old may not be safe for a frail 82-year-old who already struggles with dizziness and balance. So before you panic over one reading, or before you assume that every medication increase is automatically better, you need to understand the hidden side of blood pressure management in older adults, and that begins with one of the most important concepts most patients have never heard explained clearly: the danger of pushing the bottom number too low. Because sometimes the top number gets all the attention, while the bottom number quietly tells the more dangerous story. Most people worry about the top number. If their blood pressure is 145 over 68, their eyes immediately go to 145. If it is 138 over 60, they still focus on the top number. They ask, is my systolic too high? They rarely ask, is my diastolic too low? But after 65, that bottom number deserves serious attention. Your diastolic pressure is the pressure inside your arteries when your heart relaxes between beats. That may sound less important, but it is not. During that resting phase, your heart muscle receives much of its own blood supply through the coronary arteries. In simple terms, the heart does not just pump blood to the body, it also needs blood for itself, and that blood flow depends heavily on enough pressure being maintained between heartbeats. Now imagine an older adult whose coronary arteries already have some narrowing. Maybe they do not even know it yet. Maybe they have never had chest pain. Maybe they simply assume they are aging normally. If medication pushes the diastolic pressure too low, for example into the high 50s or low 60s, the heart may not receive enough blood during that resting phase. That is why a reading like 128 over 58 may look good at first glance. But in some older adults, it deserves a deeper conversation. The top number may look controlled, but the bottom number may be too low. This is where we need to talk about something called the J-curve effect. Many people assume blood pressure risk works like a straight line. The higher the pressure, the higher the risk. The lower the pressure, the lower the risk. But in many studies, the relationship is more complicated. When blood pressure is too high, risk goes up. But when blood pressure drops too low, risk can also begin to rise again. If you were to draw that pattern on a graph, it would look somewhat like the letter J. That means there may be a point where lowering blood pressure further does not protect the person more. Instead, it may begin to create harm. In older adults, this concern often becomes especially important with the diastolic number. When the bottom number falls too low, especially below the low 60s, some people may experience fatigue, dizziness, weakness, chest discomfort, confusion, or reduced exercise tolerance. Others may not feel obvious symptoms, but the body may still be under stress. This is why you should not look at your blood pressure as just one number. You need to understand the relationship between both numbers. Let's say two people both have a systolic pressure of 142. Person A is 67, active, strong, no dizziness, no kidney issues, and their reading is 142 over 82. Person B is 79, on several medications, sometimes lightheaded when standing, and their reading is 142 over 58. Those two people should not automatically be treated the same way. For person A, lowering blood pressure may be straightforward and beneficial. For person B, pushing the top number down aggressively may drop the bottom number even further, creating more risk. And this is exactly where individualized care matters. Now, let me be clear. You should never stop or reduce blood pressure medication on your own. That can be dangerous. Some medications must be adjusted slowly, and stopping suddenly can cause rebound hypertension or other complications. But you absolutely can ask smarter questions. At your next appointment, ask, "What has my diastolic pressure been averaging?" Not just today's number, the average. Then ask, "Is my bottom number ever getting too low?" If your diastolic pressure is often below 65, that deserves a specific discussion. If it is frequently below 60, it becomes even more important to review your medication plan, symptoms, and overall risk. Another thing many people do not realize is that clinic readings can be misleading. Blood pressure often rises in a medical office because of anxiety. This is sometimes called white coat effect. You may sit in the waiting room, worry about what the doctor will say, walk into the exam room, have your cuff placed quickly, and get one elevated reading. Then that number becomes the basis for treatment changes. But your daily blood pressure at home may tell a different story. That is why a validated home blood pressure monitor can be extremely useful. Ideally, use an upper arm cuff, not a wrist monitor, unless your doctor specifically recommends otherwise. Sit quietly for 5 minutes before measuring. Keep your feet flat on the floor. Rest your arm at heart level. Do not talk during the measurement. Take 2 readings 1 minute apart and write down the average. Do this at consistent times, such as morning and evening, for 1 or 2 weeks before your appointment. That log can give your doctor a much better picture than one rushed office reading. And when you write down your numbers, do not only write the top number, record both. The pattern matters. For example, if your readings are often around 135/72, that tells one story. If they are 132/58, that tells another. If they are 155/80 in the morning, but 118/60 at night after medication, that also matters. Blood pressure is not static. It changes throughout the day. It responds to stress, hydration, sleep, pain, meals, exercise, alcohol, caffeine, and medication timing. This is why ideal blood pressure after 65 is not one universal number. It is a range that must be understood in context. Many older adults have spent years believing that any number under 130 is automatically a victory. But after 65, the victory is not just a lower number. The victory is stable blood flow, protected organs, clear thinking, safe walking, fewer side effects, and a treatment plan that fits your real body. And that brings us to one of the most overlooked blood pressure dangers in seniors. The dangerous drop that happens not while you are sitting, but when you stand up. There is one question I wish every adult over 65 would ask themselves. Do I ever feel dizzy, lightheaded, weak, or unsteady when I stand up? Not after running. Not after exercising. Not after climbing stairs. I mean simply standing up from a chair, getting out of bed, rising from the toilet, or stepping out of the car. If the answer is yes, your blood pressure may be doing something important that nobody is measuring. This is called orthostatic hypotension. Orthostatic hypotension means your blood pressure drops significantly when you move from lying or sitting to standing. In a healthy response, your body quickly tightens blood vessels, adjusts heart rate, and keeps blood flowing to the brain. But with age, that response can become slower and weaker. Your blood vessels may not tighten quickly enough. Your nervous system may respond more slowly. You may be slightly dehydrated. You may have reduced muscle strength in your legs, which affects circulation. And if you are taking blood pressure medication, especially more than one, the drop can become more pronounced. The result is that for a few seconds, your brain may not receive enough blood flow. That can feel like dizziness, blurred vision, weakness, pressure in the head, or a strange moment of instability. Some people describe it as the room moving. Others say they feel like they are about to black out. Some do not feel dizzy at all. They simply lose balance. In younger people, this may be a minor inconvenience. In older adults, it can be dangerous. A fall after 65 can lead to a wrist fracture, head injury, hip fracture, hospitalization, loss of confidence, fear of walking, and reduced independence. Many seniors never fully return to their previous level of activity after a serious fall. That is why dizziness when standing should never be brushed off as just getting older. It may be a medication clue. It may be a hydration clue. It may be a blood pressure target clue, and it should be evaluated. Here's what makes this issue so easy to miss. Most blood pressure readings in clinics are taken while the patient is sitting. You sit down, the cuff goes on, the number is recorded, and the appointment moves forward. But if your blood pressure looks fine while sitting and then drops sharply when you stand, that danger may never appear on the chart. That is why a standing blood pressure test matters. A basic version looks like this. Your blood pressure is measured after sitting or lying quietly, and then it is measured again after standing, usually within 1 to 3 minutes. If the top number drops significantly, or if the bottom number drops too much, that may indicate orthostatic hypotension. If you have symptoms, ask your doctor directly. Can we check my blood pressure sitting and standing? Use the phrase orthostatic hypotension. It tells your doctor exactly what you are concerned about. This is especially important if you are over 75, taking multiple medications, have had falls, feel weak in the morning, get dizzy at night when going to the bathroom, or feel unusually tired after your blood pressure medication. Nighttime bathroom trips are another overlooked danger. Many seniors wake up at night to urinate. They are sleepy, the room is dark, they stand quickly, and if blood pressure drops at that moment, the fall risk increases sharply. A person may not even remember feeling dizzy. They may simply wake up on the floor. That is why blood pressure management after 65 must include daily function, not just numbers. Ask yourself, am I walking safely? Do I feel steady? Do I feel mentally clear? Do I feel weaker since my medication changed? Do I feel lightheaded when I stand? Have I stopped doing things because I feel unstable? These answers matter. A blood pressure medication that looks successful on paper may not be successful in real life if it causes the person to stop walking, stop exercising, or become afraid of movement. Losing mobility can create its own health risks: muscle loss, weight gain, poorer balance, worse blood sugar control, lower mood, and increased dependence. This is why your treatment goal should protect the whole person. Let me give you an example. Imagine a 78-year-old woman whose blood pressure has been around 145/70 for years. She is active, lives independently, walks every morning, and has no major symptoms. Then her treatment is intensified to bring her systolic pressure below 130. 6 weeks later, her readings are often 126/58. On paper, it may look like a success. But now she feels tired. She gets dizzy when standing. She stops walking outside because she is afraid of falling. She begins holding onto furniture in the house. She cancels social activities. Her confidence drops. Was that treatment truly successful? Maybe not. Again, this does not mean high blood pressure should be ignored. It means the treatment must be balanced against real-world safety. For some older adults, a systolic target around 130 may be appropriate, especially if they are strong, independent, and at high cardiovascular risk, but not prone to dizziness or falls. For others, particularly those who are older, frailer, or already experiencing side effects, a less aggressive target may be safer. The goal is not permissive care. The goal is precise care. This is also why you should bring a complete medication list to every appointment. Include prescriptions, over-the-counter medications, sleep aids, pain relievers, supplements, and anything you take only sometimes. Some medications can worsen dizziness or lower blood pressure indirectly. Others may affect kidney function or electrolytes, and medication timing matters too. A dose taken in the evening may affect nighttime standing. A morning dose may cause dizziness after breakfast. A diuretic may increase bathroom trips and dehydration. These details can change the conversation. Your blood pressure target should never be separated from how you feel and function. So now the question becomes, what number should adults over 65 actually aim for? The honest answer is not as simple as a single universal target, but there are practical ranges and conversations that can help you and your doctor make a safer decision. So what is the real ideal blood pressure after 65? The most honest answer is this: there is no single perfect number for every older adult. And that may be the most important lesson of this entire video. The right target depends on your age, strength, medical history, risk of stroke, risk of heart attack, kidney function, memory, medication tolerance, fall risk, and how your blood pressure behaves during real life, not just in the doctor's office. For a healthy, active adult between 65 and 75, especially someone with good mobility and no major frailty, many doctors may aim for a systolic pressure somewhere around the 130s. In some people, a target under 130 may be reasonable if it can be reached safely without dizziness, kidney problems, or a very low diastolic number. But for adults over 75, especially those with frailty, multiple conditions, frequent dizziness, a history of falls, or low diastolic pressure, the safest target may be different. In many cases, a systolic range closer to 140 or even 150 may be considered more appropriate depending on the person. That does not mean high blood pressure is fine. It means the target must be individualized. A strong 68-year-old and a frail 86-year-old should not automatically be managed the same way. This is where you need to become an active participant in your own care. Not by arguing with your doctor, not by stopping medication, but by asking the right questions. Here are the 5 questions I recommend bringing to your next appointment. First, what blood pressure target are we using for me and why? This question matters because many patients are treated according to a general target without ever hearing the reason. Your doctor should be able to explain why that goal fits your specific situation. Second, what has my diastolic pressure been averaging? Remember, the bottom number matters. If your diastolic pressure is often below 65, especially if you have fatigue, dizziness, chest discomfort, or brain fog, that should be reviewed. Third, could any of my medications be contributing to dizziness or low pressure when I stand? This is especially important if your symptoms began after a medication change, dose increase, or addition of a new drug. Fourth, can we check my blood pressure sitting and standing? This can reveal orthostatic hypotension, which is often missed when only sitting readings are measured. Fifth, is my current treatment protecting my long-term health without increasing my fall risk or affecting my daily function? That is the balance: protection without overcorrection. Now let's talk about what you can do at home. Start by measuring your blood pressure correctly. Do not check it immediately after walking, eating, drinking coffee, arguing, watching stressful news, or rushing around the house. Sit quietly for 5 minutes. Keep your back supported. Keep your feet flat. Place the cuff on your upper arm. Rest your arm at heart level. Take 2 readings and write down the average. Do this consistently for 1 to 2 weeks. Morning and evening can be helpful, but follow your doctor's instructions if they give you a specific schedule. Also, write down symptoms next to the numbers. For example, morning, 132/62, felt fine. Evening, 118/58, dizzy when standing. After medication, 124/60, very tired. This kind of log is powerful because it connects the number with your real life. Also, pay attention to patterns. Is your blood pressure very high in the morning but low at night? Does it drop after meals? Does dizziness happen after taking medication? Does your bottom number stay low even when the top number looks controlled? These patterns are more useful than one isolated reading. Another important point: do not chase perfection. Many people become anxious and check their blood pressure too often. They see one elevated number and panic. But blood pressure naturally changes throughout the day. One reading does not define your health. The trend matters more. If your blood pressure is repeatedly very high, that needs medical attention. If your readings are repeatedly too low or associated with symptoms, that also needs attention. Both extremes matter. Now let's imagine a safer approach. Instead of saying, "My blood pressure must always be under 130/80, you might say, "My doctor and I are working toward a range that lowers my stroke and heart risk without making me dizzy, weak, or unsafe." That is a much better goal, because after 65, good medicine is not just about numbers. It is about protecting your brain, heart, kidneys, balance, mobility, and independence at the same time. This is the message I want you to remember. Your blood pressure target should fit you, not your neighbor, not a younger adult, not a generic chart. You. If you are over 65 and your doctor has never discussed your bottom number, your fall risk, your standing blood pressure, or how you actually feel on your medication, then it may be time to ask for a more complete conversation. Not because your doctor is wrong, but because your body deserves nuance. And you deserve to understand the reason behind every target you are asked to follow. Before we finish, please comment below with one of these 3 phrases. Comment, "My numbers," if you are going to start tracking your readings more carefully. Comment, "Getting clarity," if you plan to ask your doctor about your personal blood pressure target. Or comment, "Too low," if you have ever felt dizzy, weak, or unsteady after blood pressure treatment. And please share this video with someone over 65 who may be worried about their blood pressure, but has only been told one side of the story. I'm Dr. Amanda Collins. Subscribe to the channel, like this video, and turn on notifications so you do not miss the next health warning that could protect your independence, your heart, and your future. Take care of yourself, and remember, after 65, the goal is not just a lower number. The goal is the right number for you.